Good evening, and I'd like to welcome everybody to the first webinar that Rocky Mountain Vein Clinic is putting on. This is our first webinar and my first run through this, and it may be a little confusing. Some people may not be familiar with this technology, so please keep that in mind and bear with me as we go along. Jerry's producer will be helping us out. I can see that some people haven't dialed in properly, it looks like, and you may not be able to interact. But for the most part, everybody's muted right now, just so you know that. You can hear me, but we can't hear you until I unmute you. I think the easiest thing for everybody is if I can go ahead and go through these slides. I'll answer most of the questions likely with the slides. And at the end, as Jerry alluded to, we can have a Q&A session. And if you click your raise hand button, I can click that and unmute you so I can hear your questions, or use the chat box, and I'd be happy to answer them for everybody. But anyway, I'm going to go ahead and start through this slide presentation, and I hope that you get something out of this. I'm Bo Johnson. I'm the medical director and founder of Rocky Mountain Vein Clinic. I'm a board-certified phlebotomist and general surgeon. What we're trying to do is a 30-minute webinar, and I want to get the word out to people basically what varicose and spider veins are and how we treat them. Treatment of venous disease has radically changed over the last 8 to 10 years, and it's completely different than when I was in training. So one of my missions is to try to get the word out to patients as well as physicians, because a lot of people really don't understand what the modern state-of-the-art care is. I'd like to go over the symptoms of vein disease and the newer treatments and our six-step treatment plan. Well, what are varicose veins? I think when we say that, people think of the big bulgy veins on the skin, and that's true. Varicose means dilated, and the veins can be on the skin, the ones you see, or down deeper. They're usually the result of a larger vein that runs deeper in your thigh that has broken valves that allows blood to back up and go backwards and increase the pressure, and that's what makes the vein dilate. If you look at the picture on the right, this shows a normal vein and a dysfunctional vein. This next slide will be a little more helpful. The picture here on the left, where the red dot is, this shows a normal vein. And just for orientation, the heart is towards the top of the screen and the foot is towards the bottom. And how our veins normally work, the muscles act as a pump. And when you walk or move, your muscles contract and squeeze down, and that forces blood up the veins. The valves are little one-way check valves, basically, and they kick open when the blood goes through. When your leg relaxes, or if you stand or sit for any length of period of time, the blood backs up and goes down the vein and catches on the little valve cuff. You can see right where the red dot is, and they snap shut. And that's what they do in a normal situation. If you have venous disease, the veins are more dilated than they are more elastic than they should be, and they stretch out, and the little valve cuffs then no longer meet as this vein dilates. And then if you're standing or sitting for any length of time, the net flow of the blood is down your legs. And the key to remember is that vein blood has very little oxygen in it, and it's this cooling or backing up of vein blood in your leg that causes all the symptoms that are associated with venous disease. We'll get into those symptoms a little bit later. Well, who gets varicose veins and why? Well, it's extremely common. At least a quarter of the population has treatable venous disease, about 25% of women and 18% of men. The biggest risk factor is heredity. If one parent has venous disease, there's about a 70% chance that children will have it. If both parents have venous disease, 90% chance. So that is by far and away the most significant risk factor for vein problems. Pregnancy is another very, very common precipitant of vein disease. And what happens with pregnancy, as most of our female listeners will tell you, their blood volume increases by about 15%, and that causes the veins to dilate. There's also a mass, the uterus is in the pelvis, and it blocks the outflow of the veins from the legs. And that increases the pressure in those veins. And lastly, during the last couple of weeks of pregnancy, a hormone called relaxin is secreted that causes the connective tissue to be more elastic, and that also affects your veins as well. So pregnancy and hereditary are really the two biggest risk factors. Occupations that require prolonged standing or sitting are also risk factors. The most common patient that we see by far are teachers. Nurses are second, and then we see all sorts of other people that stand for long periods of time, like bank tellers, truck drivers, cooks. Anytime that you traumatize a vein with either a blood clot, which destroys the valves in the vein, or if you get direct trauma to the vein, say a horse kicks you in the thigh or a softball hits you in the thigh over the vein, you can traumatize that vein and injure the valves, and they can become dysfunctional. Well, why do they cause medical problems? As I stated earlier, vein blood has very little oxygen, and when it's the blood that's already been through the tissues that needs to get back to your heart to be pumped through the lungs and then back out through the arteries and down the legs again. And when it backs up, the tissue becomes bathed in the blood with little oxygen, and basically gets oxygen deprived. And that's really what causes the problem. The cramping and itching and restlessness associated with vein disease are really the cause, because of the venous blood is backing up. The symptoms are really variable. It's rare that someone has all of the symptoms, but most people have some of them. And the really interesting thing about vein disease is that a lot of people that have very significant vein disease don't realize that their legs bother them. It's something that comes on over the course of about 15 to 20 years, and a lot of people just perceive their legs as being normal. Whenever I start talking to patients about the symptoms and they start thinking about it, oftentimes they'll realize, yeah, I do have those symptoms. I just thought I was getting old, or my mom had these problems, and that's why I have them. And the reality is, mom had them probably because she had vein disease and passed it on to the son or daughter. The very common symptoms that I hear the most often are a really heavy, aching, tired, fatigue feeling. It's not really pain, but it's discomfort, and people usually have a very difficult time finding a word to describe it. It's not painful, but it's uncomfortable. It's really bothersome, but it doesn't hurt, but it's aching, and at the end of the day, leg elevation usually helps it. Restlessness is a very common symptom as well. One of the most common causes of restless leg syndrome is venous disease. And if you think about it, there's a reason for that. If your blood pools up, the venous blood pools in your leg, and the only way we really get it out of our legs is with muscle contraction. That's the actual pump that pumps it out of your legs. And your brain triggers a reflex to move your legs to contract your muscles to get the blood out. Itching is another very, very frequent symptom of vein disease. And lastly, this is an obvious one that you don't need to be a doctor to notice, but venous ulcers are sores that are usually down near the ankle that stay open for months at a time, are very difficult to heal, and quite painful. And they're the result of having that venous blood pool up near the skin and making it unhealthy. And then as soon as you get a small nick or an injury to that skin, it takes months for that to heal. Usually the symptoms of vein disease are made better with elevation, exercise and walking, and venous compression stockings. Anything basically that gets the blood moving out of the legs again. Here at Rocky Mountain Vein Clinic, we try to have a very systematic approach to vein disease. The first hurdle really often is to recognize the symptoms. And so we spend a great deal of time going through the patient's symptoms and how their legs feel and what tends to make them better or worse. Really the fundamental part of the exam, though, really the thing that tells me whether or not you have vein problems and how bad they are, is a very specialized ultrasound. We have techs that specialize in vein disease and vein ultrasound, and we spend usually about an hour on looking at both legs, and we make a map of all the major veins in your leg, and that's really important, and lets me see where, or if there is a problem, where it is, and allows me to formulate a treatment plan. I think patient education is incredibly important. I think this is something where my role as a doctor is to educate the patient about the problem and make them somewhat of an expert, and then they can choose the treatment plan that seems to fit their needs the best. I wouldn't let somebody make a bad decision, but I think that clearly the patient's the one that needs to make the decision, not me. Treatment with an experienced phlebologist is also very important. There's a lot of people that treat vein disease as a kind of a side adjunct to the practice. And I think wherever you may be, if you see somebody that specializes in vein care, you'll probably get a more comprehensive approach. Lastly, as we learned earlier, vein disease is a hereditary problem, a genetic problem. And if I fix leaky veins, I can fix those veins, but I can't make other veins not become leaky in the future. You can certainly slow that process down by fixing the broken or leaky veins that you have currently. But long term, if I don't follow you and check you periodically every year or so, then you're likely going to have a significant recurrence. So we try to maintain a long-term connection with our patients. Well, how are they fixed? There's still people doing the old way, it's called vein stripping. And that's basically where you put a device up inside the vein and tie the vein to it and then pull it out. And it's been a treatment for many years, but it's really outdated, and there's really nobody that should have vein stripping anymore. Anything that's stripped, we can treat with a new inside the vein treatment, or endovenous ablation is what it's called. In this animation below, it kind of goes over the basic concepts. A little device that generates heat, either a laser or another device called radiofrequency ablation. These catheters are introduced inside the vein, and then energy is applied, and heat and causes the vein wall to contract, and we pull the catheter out slowly, and it seals the vein shut, and then over time, your body will absorb it. So that's really the thinking and the process behind how we treat veins nowadays. The newer treatments we do completely in the office. We use a small amount of local anesthesia, and I have a couple of videos that will demonstrate this to you better than the words will, but just as an overview, they're minimally invasive. They're not very intrusive into your lifestyle afterwards. I ask people to be very active. There's a little bit of discomfort associated with it, but it's typically not very painful afterwards. And really, the only limitation in your activity is I don't want you doing a lot of lifting or straining. As I mentioned before, the two technologies we use are laser, and the other one is RFA, which stands for radio frequency ablation. These are two different ways of doing the same thing, generating heat. Oftentimes we need to combine these technologies with other treatments, such as microthrombectomy, which I'll talk about a little further, but basically that's using very small incisions to remove the large bulging veins at the surface of the skin. And the other is ultrasound-guided foam sclerotherapy, and that is where we inject some medicine in the vein to get the veins closed in similar fashion. I'll show a video now of the radio frequency ablation, and I'll narrate this, but it's an animation in it, and it gives a pretty good overview. I'm going to wait just a second here and let everybody get it downloaded. We introduce the catheter inside the vein, and it's usually a long vein in the thigh that goes up to the groin, and that's what this catheter is doing right here. Then the treatment part of the catheter then is exposed, and that needle on top shows us injecting some fluid, which is a dilute numbing solution. I put that all around the vein, through the entire course of the vein, and that does several things. It numbs up the vein so it doesn't hurt. It compresses it down so it's closer to the catheter, and it protects the surrounding tissue. Now, these are little collagen fibrils. They're part of the connective tissue in the vein, and they're little coils, and that heat causes those coils to shrink up. And there's a view from the inside of what I think it might look like. Anyway, it seals that vein shut, and then the catheter is removed. And then over time, the vein becomes just a tiny little fibrotic strand, and your body just absorbs it. Now, the next video is a patient video that we shot here recently, and it shows a combination of treatments. There's two different patients. It's kind of hard to tell between the two. But one is the laser and one is the RF, and I'll try to show you the important parts. But this was shot here in our Billings Rocky Mountain Vein Clinic. First thing we do is when you come in, the ultrasonographer will mark where the vein is. She uses a little straw that dimples on the skin, and then she'll connect the dots there with a Sharpie pen, and that line will come off in a reasonable amount of time. And I put a special surgical soap that preps the leg and reduces the risk of infection. And so we put that over the entire leg, and then we put some sterile drapes around so just the leg is exposed. And the next thing I need to do is to evaluate the vein and kind of get my treatment plan. And I need to access it then. So what I do is I put a little numbing medicine in the skin, which I'm doing right there. That stings. That's the only part that really hurts. And then I put a little needle here into the vein, and I use the ultrasound. That's what that plastic thing on the left-hand side of the screen is. But I use the ultrasound to guide the needle into the vein, and you really don't feel any of that because I've already numbed up the skin. And here's the ultrasound picture that I'm looking at, and it's maybe kind of hard to tell, but I'm using the vein as that long dark tube right there, and the moving part is the needle going into the vein. And then through that needle, once we get it in, I put a little guide wire, which then allows me to run a catheter. This is the catheter for the radio frequency treatment. That gets right over that guide wire and slips right into the vein. And there's a laser fiber that we use when treating with the laser. And that's the radio frequency catheter. So basically the process is the same. We just, depending on which catheter we put in. This particular portion I'm putting in the radio frequency catheter, and then what you don't see is the ultrasonographer showing me the tip of the catheter up in the groin, and we positioned it away from the beat system so it's safe. And then at this point we need to put in that numbing medicine around the vein. And most people feel this part, but it's really most people will say it just feels strange. You can see the patient there. She's watching the video, not really being bothered by it, and it's not usually not a very unpleasant experience. It's something that most people tolerate quite well. The catheter now is in place, and I push the button to turn it on, and it's actually in the process of closing that vein right now. So I slowly will pull that catheter out over the next several minutes, and that just seals that vein shut. People don't feel this part. The only thing they feel is the pressure of my hand on the leg, and the ultrasound probe we use to compress the vein as well. Once we're done with that, then we'll remove those catheters, and then we'll put a Band-Aid on, and they'll demonstrate that here in just a second. After we're done, this is a completion ultrasound, and so we check everything that stays closed and make sure everything looks good. Then we wipe the soap off that we put on your leg to start with, and there's the entrance site. So that's really the only incision, really, is that little spot right there, and we don't even put stitches in it. We just put a Band-Aid on. And then, of course, the compression stockings, which is really the worst part of it. People have to wear those afterwards for quite a while. And then this is the patient walking out of the room. And then when we're through with the procedure, we have you walk on the treadmill for about 10 or 15 minutes just to get the blood moving and reduce the risk for blood clots in your leg. That's really about the extent of the procedure. It's something that people tolerate really quite well and normally have a pretty good time during the procedure. I thought I would go through a patient just to give you an idea of a typical patient. And this is a lady that we've treated within the last 3 months or so. A very common, very typical patient. A 36-year-old female. She's a school teacher. Has 3 kids, and her mom had bad varicose veins. She came in, and her complaints were very typical. Again, aching, fatigue. At the end of the day, her legs felt leaden. She had really bad cramps at night in her feet and in her calves. She also had restlessness in the car. She couldn't sit still. And at the end of each day, she had some swelling, and her socks would leave big creases in her ankle. On exam, she had some large ropey veins in her right leg just below the knee. They weren't terrible looking, but they certainly were noticeable on exam. And we just performed an ultrasound, and indeed she had 2 significant leaky veins in the left leg and 1 large one in the right. I recommended closure of the dysfunctional veins, and we did that with a radiofrequency ablation. And then she had 1 treatment in each leg afterwards of the ultrasound-guided foam sclerotherapy. Afterwards, she was pain-free, very pleased with how her legs felt and looked, and she made sure we understood that she had a lot more energy and her legs felt a lot lighter. This is actually her legs. These are the before pictures, and again, you can see she has the varicose veins right here with the red dots over her lower leg. But that's really the extent of what it looked like, but she really had significant symptoms. These are her legs a month after treatment, and this is a pretty typical result. This fella is pretty impressive. He came in telling me his legs didn't bother him that much, and his wife made him come in. And after we started talking with him, he decided that maybe he did have a few of those symptoms, and we closed 2 veins in each leg. And we did that microphobectomy that I'll talk more about here in a minute, but removed those big bulgy veins through tiny little incisions. And here's his picture a month after his last treatment. So he had a pretty dramatic response, and he is one of my happiest patients that I've treated. He has told me many times that he didn't realize how much his legs bothered him. This is another patient that we treated probably 8 months ago. 46-year-old, she's a nurse, and she had that vein that runs down the side of her leg there was really throbbed and ached towards the end of the day, and she had some mild cramping and itching now down near her ankle. We did a microphobectomy on that vein, and the one that you can see, and closed the big leaky vein in her thigh, and this was her picture about a month after her treatment as well. Lastly, this was a 42-year-old cook, and her complaint really was these veins down in her calf right here really ached and really throbbed at the end of the day. She would stand and cook all day long, and they would become quite painful. She also had the other symptoms of cramping and restlessness, but that wasn't her major concern. That was really how badly these veins hurt. We closed 2 veins in her leg and removed these through the small incisions, the microphobectomy. And here's her picture about a month after her treatment as well. The microphobectomy, I've used that word a lot, and basically I wanted to explain that. And a lot of people confuse this with stripping, and this is not stripping. What we do is we mark the big bulgy veins before the procedure, and then close the big leaky veins with the treatment catheters. They're the veins that feed these big bulgy veins. They close those, and then we go down and use a tiny needle to make little pinholes. And you can see this in this patient. This is upon completion. It looks like somebody may have gotten after you with an ice pick, but there's this tiny little poke holes that heal up very rapidly, and they're so small we don't even close in the stitches or anything. They just seal up. So we put these little poke holes next to the vein and use a device like this, grab the vein, and actually remove it. It sounds terrible, but it's usually a pretty boring part of the procedure, and most people fall asleep. So we remove the veins in little strips like these shown here on this upper slide. It again sounds terrible, but in reality the only part that's uncomfortable is when I have to put some numbing medicine around those veins, and that usually takes about 3 or 4 minutes, and then it's totally numb. The other term that I've been throwing around is sclerotherapy or ultrasound-guided foam sclerotherapy. And that's basically closing a vein by using a medicine that injures the vein and makes it clot. With foam sclerotherapy, we mix this liquid medicine with a little bit of air, and it makes it frothy or foamy. And by doing that, it makes the medicine a lot more effective. So I can treat a lot more vein with less medicine. So we use the ultrasound to find the leaky veins, and then it helps me guide a needle into the vein, and then I inject the medicine. And then anywhere that vein goes, the medicine travels, and it closes the vein. And it's a very effective way to treat veins called perforator veins, which are those veins right here in the middle. And also little veins or branches of this that go to the skin are spider veins. So if you inject here, it can travel out to the skin, and you can treat large segments of spider veins with just one injection. Here's a picture of a typical patient before and after foam sclerotherapy. So these veins that you see on the side of her leg are branches of probably one of these little perforator veins, and we injected into this area, and it traveled out, and so large segments of these veins were treated with one injection. The other supplemental treatments, they're almost always used after we close the big leaky veins, and this is to give you a long-term effect. As we mentioned, the foam sclerotherapy is just about everybody ends up with some of that, just to get all the veins that are the result of having the big leaky veins in the thigh. It blows out the smaller perforator veins in the lower leg. Those are the result of having had the vein problem. So we treat the vein problem with the lasers, and then down the road we inject the foam to treat the result of having had that problem. So that's a real common treatment that the majority of people end up having. We've just started a new laser program. It's called a cutaneous laser. The difference between this laser and the laser that we use to close the veins is that this one is handheld, and we treat the veins on the surface of the skin with it. That's a very effective way to treat spider veins, and it's especially good with the little spider veins in the face and the nose and anywhere in your leg. The only other way to treat those spider veins is with visual sclerotherapy, and the difference between this and the ultrasound guided is that I use my eyes to find that vein visually and inject it. So you end up individually injecting a lot of veins. Insurance generally considers the cutaneous laser, the Gentlemax laser, and visual sclerotherapy a cosmetic procedure, but the ultrasound-guided foam sclerotherapy they recognize as a medical treatment that it is. I kind of put together some pearls of wisdom, I call them. But I was trying to think of what if somebody said, if you could just tell me a few things about vein disease, that would really give me some good information. I think these are the things that most people ask me. If you see a bulging vein on your leg, you have a vein problem, and it's probably the tip of the iceberg. You probably have larger veins in your thigh that are the source of that. Something has allowed a valve to break and increase the pressure on your vein, and the vein is dilated in response to that pressure. So if you have a bulgy vein, you have something going on inside. As a corollary to that, you don't have to have bulgy veins to have vein disease. Probably 30% of my patients, if I showed you a picture of their legs and said, do you think they have vein problems, you'd say no, but they have all the symptoms. So it's not necessarily a visual problem. If you have those symptoms, very likely you have vein disease, and at the very least you should consider getting an ultrasound to see if you have any leaky veins, because it's something that's very easy to fix. The ultrasound is a fundamental part of this, and it's important, and it's a very specific type of ultrasound. It's important to understand that. If you just go down to your local hospital and say, I need a vein ultrasound, you'll get one that takes about 15 minutes, and they'll tell you that you don't have any blood clots in your leg. And that will not do anything to tell me about your vein, the status of your veins. This is a very detailed, specialized vein mapping of all of the major veins in your leg. And that's really what you need to have in order to find out if you have significant vein problems or not. This next point is something that's really important, and most people don't understand that, including physicians. That this is a medical problem. It's not a cosmetic problem. I've been doing this for over 6 years, and I can't think really of any cosmetic patients that I've treated. It's something that affects people's life on a daily basis, and it's a medical problem, and it's considered that by your insurance as well. Most people underestimate their symptoms. That happens, as we mentioned earlier, because the symptoms come on over 15 or 20 years, and you don't realize it. You think, well, that's the way my legs always feel. That's normal to me. The interesting thing is we frequently treat both legs because it's a genetic problem. So we fix one leg and the bad one, and then there's usually a month in between, and during that month I get many phone calls saying, we need to get this other one fixed right away, it's just killing me. So once they realize how good their leg can feel, people are very motivated to get the other leg fixed. Another issue is insurance almost always covers these procedures. It's really a rare thing that it's not covered because it is a medical problem. It's been a process over the last 8 years to educate insurance companies, because anymore this is a very common procedure, and most major insurance companies are aware of it. And lastly, I'm a general surgeon. I practiced general surgery for 10 years, and I've taken care of all types of patients, and colon cancer and gallbladder problems, and everybody's usually happy afterwards and say, thanks, doc, I appreciate it. But by far and away, the happiest patients I've ever treated are vein patients. And they want to tell their friends and neighbors how great their legs feel. And I think that's because it's such a chronic problem, and within an hour it's all gone with very minimal effort, and people are just amazed, I guess. I'm not sure why, but it's very fun for me to take care of vein patients because most people are very, very happy. Lastly, I just wanted to go over our 6-step process, which I think is really important to go through each of these issues with each patient. I won't go through this again, but I would ask any of you to feel free to contact me or any of my staff in the Billings office or in my Cody office. My website is a very good resource for information, and if you just want to go find out more about vein problems and its treatment, these videos also are on the website. that's a really good resource. There's also some links on the website to other sites that are very useful as well. Email also works, info@RockyMountainVeinClinic.com, and Facebook. We've just started a Facebook page, and we update that regularly and try to keep people posted as to what's going on. Well, I appreciate people taking the time to listen to this and tune into this as a new form of technology for us, and I think it's a very good way, hopefully, to get the message out in this region where we're also spread out. I would like to open up for questions now. If anybody has some, I can see that we do. Bear with me with the technology. Let me see. I'm going to unmute. Carla, can you hear me?
Yes. I have so many allergies, and my computer didn't show the video. It said that the video wasn't working. But what happens if I am allergic to some of that? What's going to happen if I do have allergies?
Okay, that's a very good question, Carla. One of the great things about this procedure is that we really only use two medications. One is lidocaine, which there's quite a bit of debate, really, whether or not there's anybody who actually has an allergy to it. And it's one of the more commonly used drugs in the world, really. So I think having an allergy to that is highly unlikely. And the only other one we use is Valium, and that's optional. So I've not experienced in probably close to 2,000 vein procedures anybody having an allergy that would keep us from doing it. But a great question. And always tell your doctor, no matter who he is, that you have allergies if you have them.
But what would be the reaction if I did?
Well, we would treat it.
You do have treatments for that?
Oh, certainly.
Okay. That's what I wondered, if I'd have to live with that complication.
Well, it's not. An allergy is an acute process. It's something you have, and then we treat it, and it goes away.
Uh-huh. Okay, that relieves my mind then. Thank you.
Oh, you're very welcome. Okay, the next question, let's see. I'm sorry, bear with me for a minute. Dell, did you have a question?
Yes. Can you hear me?
I sure can.
Okay. Well, I have problems with both of my legs. I've got the bulging and the spider veins, and so I was wondering whether that would take more than one session to deal with, because I live quite a distance from any vein clinic.
Sure. Great question. Being in Montana and Wyoming, I hear this question over and over and over again. The demographic of where our patients come from, they come from Plentywood, Montana, which is the northeast corner of Montana, down to Ennis, which is the southwest corner of Montana, down to Lander, Wyoming, and across to Gillette, Wyoming. So it's about 1,000 miles across. So it's a problem we deal with frequently. The answer to your question is it does take multiple treatments. We try to do as much as we can each time, and we try to combine things the best we can. But ultimately, it's not something you can do all at once. Did I answer your question, Del?
Yes, and I guess I wondered how you start. I mean, is the first visit just a consultation, or can you start any procedure? That's
a good question. Great question again, Del. We have to see you first and make sure you have vein problems. And again, what we mentioned earlier is that the ultrasound is a benchmark. I have to get an ultrasound, or I can't tell what's going on. So generally, the first visit, you see Ben Hoffman, who's the PA that works with us, and he gets a lot of your information. We get an ultrasound if it looks like you need one, which by the sound of it, you do. And then if you're from far away, we try to coordinate that. Either I can see you at the same time, or if you haven't worn compression stockings, then we need to get you in those, and I'll see you back at a later date. One of the mean things that insurance companies, almost all of them, and Medicare included, they require three things before we can do any treatment. They require that you have symptoms, and they require that you have an ultrasound that shows that you have leaky veins, and they require that you have to have tried and failed conservative management for 3 months. And what that means is you have to wear compression stockings, or at least buy them and try them for 3 months. So if you haven't worn those stockings, generally it will have you come back in 3 months. I don't mind seeing you, but it ends up being a waste of your time, because I'll tell you what we can do, and then tell you have to come back in 3 months, and then we can talk about doing it then. So to save you an extra trip back, I just generally will wait. You'll come in, see the PA, and get everything diagnosed, and then I'll get some stockings, and then I'll see you back in about 2.5 to 3 months, and we'll go over the procedure and the treatment plan and get you scheduled. Does that answer your question?
Yes, it does. Thank you.
Oh, you're welcome. Thank you. Okay, Jeannie Clark, can you hear me?
Yes.
Great. Matt, do you have a question?
Yes, my question is, I'm on Coumadin for axial fibrillation. How would it affect this procedure?
Oh, excellent question. It doesn't. We do the procedures with people fully anticoagulated. As a surgeon, it's the only procedure I will do with somebody fully anticoagulated. So we don't stop the Coumadin, and actually I don't want you to stop it, because if you stop it, you're at risk for having blood clots. And if you think about what we're doing, we're closing the vein that we're treating, so we're plugging it shut. So that's why people don't have a bleeding problem afterwards, is because the vein there's a hole in it is plugged now with treatment. Does that make sense to you?
Yes, that does make sense.
So, really good question. As a matter of fact, if somebody is at risk for having blood clots, say they've had one in the past, or their parents and brothers and sisters have had blood clots, we anticoagulate them before we do the procedure.
I see. Okay. Well,
okay. Oh, thank you for your question. The next question I see is a familiar person. Margaret?
Yes.
Do you have a question for me?
Yes, I do. Tomorrow I'm going to have the sclerotherapy. And was wondering, am I still limited for 2 weeks for lifting over 2 pounds or any exercise?
Oh, great question. Actually, not 2 pounds, to 20. After we do the procedure, the limitations are really minimal. And the things I don't want you to do, I don't want you to lift more than 20 pounds or strain for probably 10 to 14 days. I don't want you to soak in hot water like a hot bath or a hot tub for a couple of weeks, because that makes your veins dilate. I do want you to wear your compression stockings. For you having foam sclerotherapy, you have to wear the stockings night and day for about 4 or 5 days, and then during the daytime for about 10 days. It's a little bit different than the other procedures that you had in the past, where you had to wear night and day for 2 weeks. But as far as activity, I want you to be very active, a lot of walking, not a lot of sitting. If you have to sit during the day, I want you to get up every hour and walk around a little bit.
Okay.
But just lifting is the main thing I don't want you to do, because when you lift, it forces blood down those veins and challenges the veins that I just closed.
Okay, and that's a 20-pound limit.
Correct. And basically anything that makes you strain, I don't want you to do.
Okay. Thank you.
You bet. Thank you. We'll see you tomorrow.
See you tomorrow morning.
I'll be here. Let's see. I think I have another one here. Susan? Can you hear me?
Hello. Yes, I can hear you. Can you hear me?
I sure can.
Can you questions about the hot tubbing and bathing. You answered that on the last call.
Okay.
The other question I had, which was fairly important, was the veins that are ropey up near your groin area, high on the inside of the thighs, are those treated in the same way? And what do you do about compression stockings for up there?
Oh, great question. It depends on where they come from. So, basically we'll get the ultrasound, and that tells me what the origin of those veins are. So sometimes those veins that come down in the really upper thigh and to the groin area, they come from the pelvis, and they really aren't part of your leg veins. They just run down into your legs. And women, frequently, when they've had multiple pregnancies, have those veins. We treat those usually with a combination of either microphobectomy, where we remove them with small little incisions, and ligation, which means we tie them off up high. If they're small, frequently we can inject them using the foam sclerotherapy, and that will take care of those quite well. As far as the compression stockings, we can usually get them up high enough to where they're effective there.
Oh, okay.
So if you're in the right stocking, we should be able to get it up high enough. And if it's not, then we need to get you in a little bigger stocking.
Well, I'm going to go get my stockings and start wearing them right now.
Oh, that a girl. That's the spirit. Everybody hates the stockings, and I've heard every bad thing about them you could possibly hear, but ultimately, once you get them on, after you get past the mental block of having to put them on, they should make your legs feel better. Once we get the veins treated, we really don't have to wear the real heavy-duty ones. We can get you into some much lighter, much more comfortable, and stockings that aren't very hot. They still do a good job down the road to help protect what you've done.
And Dr. Johnson, one last question, if you're able.
Sure.
What about those ugly little clusters of veins around your ankles? Can we take care of those too?
You bet. So, at the end of that's a very common question, and I'm glad you asked it. Yes. Those are spider veins or reticular veins or telangiectasias or all the names for those types of veins. And that's where the pressure settles in your leg, the lowest point, if the veins are leaky. So the first part of that treatment is to close the source of the problem, and it's usually the big vein up in the thigh called the saphenous vein, or it's usually 1, 2, or even 3 veins that we should close first, because that's what's caused all that. And once we do that, then we can go back and treat those types of veins with either injection, that the foam sclerotherapy I mentioned, really the best way to treat those types of veins. It will treat anywhere from 80 to 90% of those. The little tips of them that are left, we can then either use the cutaneous laser, which just clears them right up, or visual sclerotherapy. And it's usually a combination. But if I just treat those veins, if you come in and you say, you know what, I don't like these ankle veins, get rid of these, I'm going to tell you, I can do that, but they're going to be back next year in another place, and you ultimately won't be real happy with me. So it's important to treat the source of the problem, and that'll also, a lot of people will be sitting there thinking, well, my legs really don't bother me, and I can't tell you how many times I've heard that. But if you have all those things, I would bet money that you have symptoms, because you just don't realize it. So you're headed down the road of progression. If you have big bulgy veins, it's not ever going to get better, and it will only get worse with time. And it sets you up for blood clots. It increased risk for deep vein thrombosis. It sets you up for venous stasis ulcers down the road. It's a slow process. It's not going to happen overnight. But if you have big bulgy veins, there's a very simple, easy way to fix them. And, really, what's happened is it's such an easy thing to do now. The question has gone from when stripping was the only answer, why would I do that, to being now, why would you not do that? It's such an easy outpatient. You do it in the office, and a lot of people say the dentist is worse. So the question really becomes, why would you not want to fix them? What's that?
I'm just chuckling.
Oh, okay.
Yeah, the dentist is worse.
So anyway, I hope that answered your question.
Yes, thank you very much.
Oh, you're welcome. So, do I have any other questions? It looks like there's, Carla, did you have another question?
No, I didn't.
Okay.
That pretty much released my mind.
Okay.
Thank you.
Oh, you're welcome. So, I don't see any further questions. If anybody has another question, please click up your, I do see a question. Bob, you have a question.
Yeah, once my veins are all taken care of, do I ever have to see you again?
Well, most people don't, but you're going to have to. I should let everybody know that you're Dr. Bob Rubel, and you work here. And Dr. Rubel has joined our staff in January, and he does a lot of the ultrasound-guided foam sclerotherapy. So thank you for that nice question, Dr. Rubel.
How long is the treatment effective? Is the problem ever going to come back?
Well, yeah, I mean, it's a genetic problem. If you treat the leaky veins, it slows that process down significantly. But ultimately, it's something that we need to keep up with. Check you every year or so, and oftentimes just an injection here or there will keep you from getting worse problems. But it is a relentless process.
Thanks.
Thanks, Bob. Any other questions? Well, I would again thank everybody for taking the time to participate, and I hope this wasn't too confusing. It's a new technology, and hopefully a way that we can reach out and touch people. We did have one little glitch. We're supposed to be able to have a video so you can see me, but we've had some technical issues with that. But maybe next time. But I think we'll probably have a series of these talks, and I would invite you to anytime call us and participate in any of these, and certainly utilize the resources on the left there, the website, or even call the office if you can't get me. Then my staff is very adept at answering questions. But I would thank everybody for joining, and I will see some of you soon. If there's no more questions, we'll just call it an evening. Thank you.